good work.
Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live from the Dolph Simons Family Studio. We're delighted to be back with you this morning after a long weekend. Doc Hawk is on my right, and Rachel Liesman, who is really the director of our testing lab, he is on my left. I think her official title is Director of Microbiology and Pathology and Laboratory Medicine here at the health system. And Rachel has her PhD. She's been an incredible, important person to us and resources. She has led us on this testing journey here at KU, and obviously that's a really big deal that's going on out there and around the country and right here in Kansas City. Yeah. So Dana, what's the good word today?
Well, the good word is there are a few more cases in the hospital than we saw last week.
Yeah.
We've kind of ratcheted up to 24 since going from Friday till now over the weekend. 10 of those in the ICU, so almost half in the ICU, which is not good.
That's going up again.
That is going up, but only 3 on the vent still.
Really good news.
So that's a good thing. Again, we have had discharges and admissions, but overall, the positive hospitalizations is going up. So the number is going up compared to where we were. I think we were at 16, 18 for the most part of last week, maybe 18 or 19 or 20 the end of last week, but it is up.
24. And we know from our call and our discussion with CMOs over the last few weeks, that the numbers across Kansas City are clearly going up as well.
Absolutely.
And always good to get that information and to know how our city's doing. It's not Florida.
No.
It's where they had, I believe, 15,000 cases in one day on a weekend, which means you usually don't test quite as much on the Saturday or Sunday. So to have 15,000 and watch Disney World open, that's a little spooky to me.
Yeah, you know, we just have to assume, and what we've always said is that those are the cases, just the cases that we're testing. So we assume that it's out there even more than that, and it's just continuing to spread. Again, we can reduce the spread. It can be easy to decrease the chance of getting it by those simple measures that we're taking. We just need people to start taking those measures.
And to take it seriously about folks who don't mask in public for whatever reason, just remember, you know, you're not going to die in a mask. Surgeons and nurses wear masks all day long, sometimes for 12 to 14 hours at a time in the operating room or more. It is not an uncommon deal. So it's not like you're going to have that problem that you can't wear a mask. It's not unsafe. And they do it for one reason and one reason only. They do it to protect the patient. To
keep you safe.
And they do it to keep you safe. And so if it's true in the operating room, I wonder why it shouldn't be true outside or even inside in homes and with families. Rachel, testing. We thought we had it all fixed, and then all of a sudden the numbers start going up, and then let's realize, well, we're not really fixed, are we?
I don't know that we're ever going to be fixed. You know, we just keep trying to continue to build our capacity and to continue to test. We're going to report out our 40,000th test today. We've been testing for about 4 or 5 months now. I've kind of lost track. You know, I think the issues that we've had throughout the pandemic, we continue to have. We have concerns about supply chain, about getting enough swabs, about getting enough test kits. Those really haven't been alleviated, and so we continue to work for that. But we're still supporting testing. You know, we're doing about 800 or 900 a day, trying to push that number up so that we can support both our patients as well as our community.
So a lot of talk now about how hard it is to do the nasal swab. You and I are visiting a little bit. Salival testing looks like it's on the horizon. Talk to us a little bit about that.
It is. It's an interesting source. I think when this started and we were treating this virus more similarly to our classic respiratory viruses, it wasn't the most logical source. The data shows that it's pretty good. I think the data still shows that it is not as good as a nasopharyngeal swab, right? So an NP still is going to be our best source for testing patients. It is our gold standard. But certainly that's not very comfortable and requires some PPE and collection. So a lot of places are trying to bring up saliva testing. We are looking at it as well. The FDA requires that we submit some studies before we can start doing that.
So what's involved in that? What do you mean by studies?
So they require that we do a direct comparison of an NP swab and saliva collected concurrently. So we would need to enroll patients in a study, consent them appropriately, collect both specimens and test both specimens, and then demonstrate that the data shows that they're equivalent, or what the FDA has defined as equivalent. And we have to do that for, I think the numbers right now are 30 positives and 30 negatives. which is a fair number of people to kind of get consented and enrolled.
Right.
And then there's a lot of paperwork, and then the submission process, and you work with the FDA to kind of, they review your data, they decide whether or not it's adequate, and then kind of give you the thumbs up or the thumbs down. Usually they ask for some follow-up studies.
Oh, that's what the FDA likes to do.
There's never, it's usually
Keep
not
checking.
a one-shot situation.
Yeah.
Sure. Yeah.
So we're doing about 900 to 1,000 tests a day. Is that enough?
Based on the number of people that are asking us to test, no, I don't think it is. And we are looking to find ways to increase that number. Capacity is always limited, both in the hospital but in the lab, by stuff, space, and staff, right? And so we're kind of working through all of that.
Space, and staff, the 3 S's.
There are 3 S's.
I like the stuff one especially.
That's our big problem, right?
Yeah, a lot of stuff. Lab takes a lot of stuff. That's part of the problem. Labs take a lot of stuff.
We do, and we're struggling to buy stuff right now, and so that's where a lot of places we're under allocation. So when we are working with our vendors, they've said, I have 80 tests for you to do a day. And if I say, well, I would rather do 150, they say, well, I only have 80. Here's your 80. And we get those allocations weekly. And so in any given week, I don't actually know if I will have that testing the next week. And so there's a little bit of trying to prepare for the bottom to drop out. And it's happened to us a couple times. And so we like to have sufficient contingency plans so that we don't have any interruption in the testing that we kind of promised to do.
And that's the stuff. It's like that's the solution, the swabs, and all the testing
test
reagents.
kits, all of that. Yeah. So all of that has to come together. The tubes, the plastic, all of those things. And we've had shortages on virtually everything as we've moved
Can you make
through.
your own?
Well, no, not personally.
Yes.
We have not been able to make our own. I know that people have looked at 3D printed NP swabs.
Right.
I've seen some of them. They look less comfortable than a standard NP swab. They're a bit stiff.
That's what I've heard.
I think we don't know how great they are as far as like collection, but certainly when you're in a situation where it's a 3D printed NP swab or nothing, it's better than nothing. But ideally we are using our optimal testing reagents and collecting reagents and everything, and we're not always in that situation, but we strive to be in that situation.
Yeah, that's awesome. So have you had any days off yet?
None since March.
Occasionally.
Yeah, I don't think you have, Rachel. I don't think
No,
that's true. I think you get a couple of Pinocchios on that one. I'm not sure
Well, I try to take a little bit of time to maintain some sanity, but usually on email most of the time just to make sure that everything's... Dana's texting me at all hours of the day.
Put out fires, yes.
Yeah, this guy, Doc Hawk, he's always on it.
We all bow to Dr. Liesman and Dr. Plapp's knowledge and guidance as far as the lab has gone for the health system. And I think we should point out, too, that the problem with the allocation of materials is not unique to this health system. This happens everywhere, and that's why so many health systems or hospitals are on 3, 4 different platforms and use different companies for these tests.
And it's really problematic in more rural communities, right? So we're the University of Kansas. I have relationships with a lot of these vendors. We've been able to get them to bring testing in and support us with testing. A really small hospital that doesn't have a lab that has a level of molecular experience than we do, or doesn't already have a relationship with these vendors, they can't get any tests. And it's a massive problem out in rural communities that are further away from hospitals like Kansas that can kind of help them out. So the supply chain issues continue to be just a real concern as we try to test everybody.
Yeah.
And it strikes me that I hear about y'all working hard on making sure the testing is right and all the quality control. How does a lab who doesn't have somebody like you there to help guide, how do they maintain that?
Yeah, I mean, I think that the work is done at the supervisor level, and I try to support groups. We kind of know a lot of the microbiologists in our community, and in the state of Kansas and in our region, and have done some phone calls and emails with them about testing options and what they might want to bring in, and we try to give them support. We have kind of email networks and everything, but it's a challenge, certainly, especially when you're talking about bringing in maybe a test platform that they've never used before. And there's always a learning curve for that. And it's certainly much harder for groups like that than it has been for us, even considering how difficult it's been for us.
It's a scary time around some of those issues, I think, for a lot of folks. And you would hope we're 5, 6 months, whatever the number is, into this crisis. I think, gosh, we're better off now than we are. And we're better off. We're just not where we need to be.
Right.
And you think we should be able to be there. Well, let's first see if there's questions from media this morning and anybody who might have any thoughts or things that they would like us to go into. Not hearing any. Jill, I think you're back at it with this. We're so happy you're here this week. And talk to us about what are we hearing from the community?
Sharon wants to know, why is North Kansas City doing the saliva test? Are they not as reliable?
Okay, saliva test. And I don't know which hospitals are doing which. I think everybody's going towards salival testing. And there are a lot of commercial labs trying to get there too, Rachel. When do you think we've not always been the first adopter of some of that because we want to make sure that it's right before we move away from the gold standard, but others are moving toward it. It feels like sometime within the next 4 to 8 weeks that's going to become more of a standard. What are your thoughts about that?
Yeah, we've been looking at it, and I think that there are some big questions that we don't know the answers to, and so we're trying to answer those a little bit ourselves, and I'm kind of waiting for the data before we move forward. So some groups have moved to saliva because they can't get NP swabs. So it is a swab sparing approach to testing, and if you literally cannot buy an NP swab, which is a situation that many people are in, it is a good solution, a good option.
And you don't need new equipment. You can use the same equipment.
You don't need new equipment.
It's just a different sample that you run through the
Yep, you've got to do your standard verification. So the lab is going to ensure that the test runs as with the same level of quality as your NP swabs, but you can do it on the same equipment. I think most of the studies on saliva have been done in patients, in people that are quite ill. And one of the big open questions for me is how good is saliva on an asymptomatic patient on a pre-procedural screening? Because we just don't know. And moving forward with saliva testing, from my perspective, in an area where we really don't know, is the virus in the saliva or is it primarily in the NP, is something that I would want to move forward slowly with and try to gather some data before we switch all of our, asymptomatic pre-procedure testing to saliva or something to that effect.
Yeah. So Dan, let's talk a little bit about that. Is the virus shed, and what we're saying is the virus shed in your mouth as early as, specifically in saliva? Yeah. Is it shed as well there, or early there, or as detectably there as it is in your nasal cavities? Because that's where most respiratory viruses start. Yeah. So is it going to be shed, which way is it going to be shed equally, or how does that look from your standpoint as an ID doc?
We would hope and think that it would be shed in the same amounts. Again, very little data, as Rachel had talked about. But we hope, because it is coming from that area, we do know people have a lot of postnasal drip all the time and have, stuff that they can spit up, saliva they can get. So we would hope that it would be detectable in similar numbers. And again, we're looking at even, upper respiratory, which we can do saliva and nasopharyngeal, versus also other things like lower respiratory, which we don't have a lot of data. And lower respiratory means down in the lungs. So we don't have a lot of data about viral levels and titers in that area. We certainly have a lot more in saliva and NP.
And I think most of the data that I've seen has shown that saliva tends to have about 10-fold less viral RNA than an NP swab when they're collected concurrently. And there's quite a bit of variability. So in a patient where they have a ton of virus, it's not really a concern, because even if you have 10-fold less, you still have a ton of virus. But we have some patient populations where they just have a low level amount of virus, and we're still catching them on an NP swab. And I think the unanswered question is, would we catch those people with saliva as well? And those studies are ongoing.
Okay, and that's why we have to standardize it. If you want to run one against, if say, a hero on my set who just turned positive with NP swab was the sputum also, or the saliva also positive.
Sure.
Yeah. And I've seen one or two references too, and again, it's a small amount of data where actually saliva was actually positive longer than NP swabs as well. So there is that discordance there, and we just got to figure out how to deal with all of that, and really moving forward, what do we use the saliva for and how?
So I think a lot of sports organizations, and
Yeah.
we've been talking about the University of Kansas even using salival
Yeah.
testing.
Yeah.
So I think we're hopeful that that's going to work out because it is so much easier to collect,
Yes.
and it doesn't require a lot of healthcare personnel, and you can spit into a tube, get it, and you're on your
Yeah.
way. But the NP swabs are hard. Have either of you had one yet?
No, I have not.
I haven't for this pandemic, but I have had numerous NP swabs in the past because I worked in a respiratory research center.
Oh yeah.
And they needed my cells, so.
Oh, you would
Yeah.
You would be a giver. That's just great.
Yep,
I've
so-
been tested twice in the pandemic,
Yeah.
and was negative both times, fortunately. And then and it's really the same thing as an influenza swab, right? Isn't that the same swab essentially? And so I know that it can really hurt,
Right.
And it does feel a little like a brain biopsy when you get it done correctly.
But I just, it's a temporary pain.
It is a
You know,
temporary
so I
pain,
don't
fair
want to
enough.
like scare people away from getting tested
Right,
because
yeah.
they think that an NP swab is painful. It is uncomfortable for sure.
Yeah.
But
No, you
know,
walk
it's
away.
a temp-
You're
yeah,
fine. You're
yeah,
like,
yeah.
okay, I got to blow
You
my
shake
nose
it off.
now. And well, there you go. Yeah. So
Sure.
it does.
And
you can-
our collectors are very efficient now and have gotten very good at it.
They
so
have.
they don't put you through too much discomfort.
Well, I don't know about that part, but but I would say that it's a necessary test. I mean,
Yeah.
if you don't have a little bit of discomfort, you're not getting it done right, and we want it to be done right because
Yeah.
we want the results to be meaningful. And I think that's the question about salival. How meaningful is it relative to the NP? So the NP swab will remain the gold standard. I'm hopeful that we'll find the way to with saliva with really good detection, as long as we're not getting false positives, because the detection is turned up so high that it will be a valid technique. So we'll see.
I want to personally say I had to have the test recently too, and I
Yeah.
also tested negative. And the secret, my nurse told me when she collected it, make sure your head is tilted all the way back, take a deep breath and relax, and it just takes, not, 5 seconds, if that. You know, it just goes up,
Yeah.
a little bit of a twirl, a little bit of
A
a
little bit of twirl,
burn,
a little bit
maybe.
of a move up and down as they twirl. So,
Yeah. So
it's totally survivable. You know what? You break your nail, you step on a something, or you run into the door. I run into the doors all the time. I'm a little clumsy, and so it's really not bad. It's just one of those. It's just like you said, it's a temporary pain, and then you move on.
Yeah. All right, so I'm going to totally butcher this because I'm not very good with big words. But Kathy is wanting to know about a particular therapy potential, and budesonide, Buddha, B-U-D-E.
Budesonide, I
Budesonide.
suspect is what they're asking
Yeah.
about.
Yeah,
whether
she
or
wants to
not
know if
this
inhaled
might
be
yeah.
promising. What do you hear about
It's an
that?
inhaled steroid that we use in asthma and sinus allergies, Dana. And,
Yeah, you know
and-
about that a lot.
Yeah, I use a lot of budesonide, but what do you think about it as far as an antiviral therapy?
Yeah, I would not advocate as an antiviral therapy. I think it would be one of our supportive measures. I don't know that we would see the same results that we do with the systemic or the oral or the IV steroids like dexamethasone. It probably wouldn't harm you too much. Again, I think
I mean,
we're
if you
looking
need
at-
it for other reasons, I think it's fair to be on it. I wouldn't go on
Right.
it just because you want to have viral protections. I'm not sure it will protect against the virus. And there's some data out there that inhaled steroids can make you more susceptible, not less susceptible. And so I think I'd be a little careful around that. In fact, I think I'd be a lot careful around
Yeah,
that.
I would
And,
continue using it if you are already using it.
Yeah, if you're using it because you have asthma or if you have I have seasonal allergies. I'm on a nasal steroid,
Yeah.
and if I don't do it, I sneeze all day long, and people think I have COVID and have to go down and get another swab. I don't want to do that.
You know, there was a similar thing that came out, I think, on Friday about proton inhibitors.
Yeah, but whether or not
Yeah.
proton pump inhibitors are
Yeah.
also, there's been some data out there that suggests, and it's retrospective analysis, that if you're on a PPI, you have a less severe course than if
Yeah.
you aren't on a PPI, proton pump inhibitor. And I think that's one of those things. For a while they said if you had A negative or A positive blood type, you're at increased risk. Well, then when they start looking at that information prospectively, meaning now we're looking to test for that, actually it doesn't look like that's true.
Yeah.
And so I think a lot of that's the same on depth.
Yeah, I mean, I think that is good that we have so many people looking at new therapies or drugs to help if you do have it, to reduce your severity and reduce complications. But I think there's just a lot of that going on. I'm not optimistic that a lot of that will work. But again, if you're still on these medications that they're looking at
No, stay on your meds.
for chronic medical
Yeah.
conditions, stay on those medications.
Yeah, we don't want to lose sight of that, how important that part is.
Jenny asked, the health department is telling COVID positive patients that they can stop quarantine at 10 days if they are, and she says symptomatic, but I'm wondering if she meant to say
means
asymptomatic.
Yeah.
She asked, does fatigue count as a symptom?
It does count.
Yeah.
What do you think?
So to answer that question, yeah, I mean, technically, the CDC guidelines would suggest 10 days after your initial diagnosis or initial symptom onset if you're otherwise fever-free.
Fever-free for 72 hours without any like
without
Tylenol or Motrin
ibuprofen,
or anything like that.
Yep.
Yeah.
And then, you know, I don't know that you're going to be asymptomatic. We have seen that even 60 days out, there was a new research paper published in Annals of Internal Medicine, I believe, that showed that even 60 days out, people are still having symptoms of fatigue. We know cough, shortness of breath. But if you have an improvement in your symptoms, and they are improving, I think that's reasonable, and that's technically the guidance.
It says marked improvement in symptoms. It doesn't say symptom-free, and I think that's really the key. And we know that people can shed that virus for a long time, Rachel, right? I mean, have you seen some of that data about how long folks can shed for?
Yeah, we know it's detectable for a really long time. And this is an interesting thought because we in the lab are very clear that doing what we call a test of cure is a bad idea. So if you diagnose someone with a molecular test, determining whether or not they're cured with a molecular test is a bit of a fool's errand, right?
Yes.
So we
Explain
teach
that
clinicians
a little bit.
because molecular material will stick around for a very long time, right? So we're detecting these tiny, tiny little snippets of the genetic material of the virus. And so they may be present for weeks, maybe months, but that doesn't necessarily mean that you have an active virus. It doesn't mean that you have a whole virus there. It doesn't mean that you're still infected. It doesn't mean that you're still transmitting or shedding or any of those things. And we know that with other viruses, this is why we recommend against this. We know that some patients can shed or have positive tests for a prolonged period of time with other viruses. You know, I think that this has become very, very apparent with SARS-CoV-2, but I would imagine that if some of these people got influenza and then you tested them for influenza virus for extended periods of time, you would find it in a good number of patients.
Yes.
So I don't know that it is necessarily unique to this virus. I think we've just found it because we're doing a lot of testing long term because this is new and we needed to. But it certainly doesn't mean that these patients are still infected, and there is data to support that it is unlikely that they're still shedding actual active live virus.
Yeah, and I think that's a big key, but Dana, because if you're not shedding live virus, and that's the deal after 10 days, the reason you can probably go out after 10 days isn't because you feel 100% better, it's whether or not you're still infectious to others. And I think what we know by and large is that the virus isn't infectious in people when you breathe it out after 10 days.
Yeah, I mean, again, we don't have a lot, as Dr. Liesman said, but the data that we do have, the published reports, really say you're most infectious 1 to 2 days after. One of the reports says 0.7 day, 1 to 2 days prior to symptoms to 0.7 days after symptoms. Let's say 1 to 2 days after you start to have symptoms. And really after about 8 to 10 days, you really stop shedding enough virus to be infectious or really even culturable virus. So that is good news. But again, that's the best published reports that we have. We need to continue to wait for further data on that.
Yeah, and I mean, one of the challenges with this is a BSL-3 agent, so you got to be full suited up, and so it
talk
limits.
about what BSL-3 means. You can't throw that term out there and not use it.
So this is an extra safety level than what we normally have in a laboratory, a research laboratory or a clinical laboratory, and there aren't many laboratories that can achieve that level of safety. And so this is a designation put on the virus that if you're going to work with it and grow it in a research lab, you have to achieve this level of safety. And so one of the consequences of doing that is it has a limited study of the actual live virus. So it limits our ability to grow the virus. I could not actively grow the virus like in a cell culture. And that's what Dana was talking about when saying that you can't culture this virus anymore. That is one of the ways that we could test to see if a patient still has live virus in their nasopharynx, as opposed to just finding the genetic material, which is what we're doing in the clinical lab.
Yeah. Okay.
Janice wants to know, is the testing still showing a 20% false negative rate?
Gosh, I don't think we're there.
No, I don't think so. I'm not entirely sure that it ever really showed a 20% false negative rate.
Unless you were really bad at doing the test itself. The swab,
If you are, yes, so if you're using,
you could easily be that.
If you're using a subpar collection approach, certainly, if you're looking for it in the wrong space, or if you're using an inadequate test. And in some of the earlier studies, that was potentially part of the reason that we were missing the virus occasionally. I think the approach in the US has probably had a false negative rate much lower than 20%. What it is somewhat difficult to nail down. We know we're missing patients. We have patients in our hospital now that I know that we missed, and we do some investigation around that. There are a couple reasons you could miss it. One is if you test the patient too late, so the virus is no longer in the upper respiratory tract, it's in the lower respiratory tract. So if you look for it in the upper respiratory, it's just not there. I mean, the test didn't miss it, we just went looking for it in the wrong place. And then other times, you know, it seems like it should be in the upper, and we just miss it with the test. And I don't think we quite understand that yet. That we're still kind of investigating. But I think our false negative rate is probably much lower than 20%.
And we'd like to clarify, this is probably, we're talking about the PCR test, not the antigen test, which is just looking at a piece of the virus rather than the actual genomic material of the virus. So those, if you want to talk on those rates of the antigen test, which is a rapid kind of test.
Right. So there are now 2 FDA EUA antigen tests. So our PCR test looks for the genetic material, and antigen test looks for protein made by the virus. Same type of collection and everything. Antigen tests, we've used them historically for flu detection, so they're not new to the detection of respiratory viruses. What also isn't new is that the sensitivity is poor for those. And that, I think, is still true when we look at the data on the antigen test for SARS-CoV-2, that the sensitivity, when compared to PCR, is only about 80, maybe 85%. So these are definitely inferior to a PCR test. If you have availability of a PCR, you know, we would encourage people to use a PCR test.
So, and what's a PCR? Talk to us. What is a PCR test?
Yeah, so this is our way of detecting genetic material. So we are going to take a small section of the genome of the virus. We make a lot of copies, and by making a lot of copies, we can then detect those copies.
We being people, not necessarily the lab.
The instrumentation in the lab does this. So this is chemistry that's been around since I think the 80s, maybe earlier.
Don't date me here, Rachel. Go ahead.
And so this is like the bread and butter of virus detection. Viruses classically are detected by this method. So make a lot of copies, detect them on the instruments. That's what our instruments in the lab are doing.
Yeah.
Okay.
Joellen wants to know what NP stands for with the swab. She says, and other shorthand terms, please explain
Make sure we say
the
what these
medical
are.
jargon. Yeah.
Nasopharyngeal, that means we stick it into your nose and maybe even into the back of your throat. That's what NP is a nasopharyngeal swab. And when they do the swab, they go in through your nose, and as Jill pointed out, they like you to tell you to take a couple of deep breaths and tilt your head back a little bit, because it makes it the route that the swab has to travel more direct. Whereas if you have your head down like this, it's got to make a bigger bend, and that hurts more. If you go back like this, it creates a little bit more of a straight path, and that allows you to get in a little easier and get a good sample. So NP is nasopharyngeal swab. Yeah. PCR is polymerase chain reaction, I believe, and is a technique that is used to find pieces of genetic material from the virus that's in your sinuses. And you won't have that because your body wouldn't have that in there unless there was an invasion by this virus, and that's, or any virus really. That same thing is true for influenza or you know, the rhinovirus or any of the others. So if we go looking for the genetic material and we find it and we say, gosh, you have the genetic material and you have the symptoms, we think you have COVID-19. And that's the actual relationship. Mm-hmm. The problem is the genetic material can stick around for a while in your body, as your body is now trying to attack and kill the virus. As it kills it, it breaks it up. When it breaks up, the pieces hang around for a little bit. So we can still find that genetic material in you for a while, even after you've cleared the virus, essentially, or you've recovered the illness. But the little pieces of it can be around, and we can find that for a long time. And so then the question becomes, if we find it in someone, who doesn't have symptoms, is that new or is that old? And we don't know that in an asymptomatic person.
Yeah.
We treat you as if it's new because we can't be sure. But it could be old. You could have had it from 6 weeks ago and still be having some of that genetic material around. So there you go.
All right, Stephen wants to know, can you tell us what we've learned from contact tracing? Has it been effective in reducing spread?
Oh, there's no question that contact tracing does work to reduce spread. The biggest problem with contact tracing is if you don't get to it early and often, you're not going to have it because you'll get overwhelmed. Right. I point to the cases in Florida right now, 15,000 cases in one day. If it takes an average of 4 hours to do contact tracing, which is about right on one person, that's 60,000 hours of manpower. So we have 450, or let's say 500, makes the math easier, here in Kansas. So one day of testing and do the contact in Florida would have cost 60,000 hours. If we had 500 testers here, that's like, that's just not enough people, Dana. The math doesn't work.
No, right, done correctly.
Not testers, you mean?
In the right manner, in the contact tracing.
But that is the tester. That's what I'm saying, the contact tracer, you're right.
Yeah, absolutely does work. But unfortunately, the overwhelming need for manpower and the time it takes to do that, is very important here. The other thing, we understand that even if somebody is doing contact tracing, there are people who should be in quarantine who are not obeying quarantine or staying home or really trying to do their part to reduce the spread as well. But certainly contact tracing done in the correct manner, in the right amount of time, if you have the manpower, does help and does work.
And I think this emphasizes the need for adequate infrastructure on the testing end as well. Because if it takes 5, 6, 7, 8 days to get a test back, then now you've that far behind, right?
Yes.
That ship has sailed. And so for contact tracing to be maximally successful, you need that result in 24, 48, maybe 72 hours, really.
You really
and so
do.
it's so important that we continue to support our testing infrastructure so we can get those reports out.
And it's not about that one person who you just tested. The problem is if you say to somebody, okay, look, you're getting tested, go home and isolate till we get the result. Okay, you can isolate, although it's not great, but 7 or 8 days, that's a long time to isolate. The problem is you can't go figure out who all their contacts were to tell them to isolate so they're not spreading the disease. That's where we get in trouble. So, well, why don't we just tell everybody who's had a test to go and tell all their friends or do all the contact? Well, the problem is that our testing positivity rate is what right now? About 7 to 10%.
It's certainly higher than it was.
Depends on the population you're looking for, but
overall,
ballpark around there. Sure.
So that means instead of if we're doing 1,000 a day, it means we're really doing 10 of those. Let's say 10% at most. If we're doing 1,000, we're telling 100 a day. We're going to go do contact tracing. But imagine what happens if we take that by 10 and we would have to do contact tracing just because you had a test. We can't do that. That's just not sustainable.
Kind of indirectly to your point, there was a great opinion piece by Dr. Paul Sachs, who is an international ID and HIV expert out east, who was advocating that even more than vaccination, we need rapid home testing. So are you going to do that every day, every third day? Because that will play into the contact tracing as well. And if it's more accurate, and if we can do that and people can do that at home, they can test themselves before they're going out, they can test themselves before they have to travel, things like that, if you get an accurate test. So that can also aid in the contact tracing and the mitigating the disease spread as well.
I think that's going to have to be saliva.
Yep,
Nobody's going to be sticking the nasal swab in there. Yeah, we're not doing self-MP.
And to his point was even if the sensitivity is not the same as PCR, if you are not detecting it, do you have it then even in the titers or the infectious virus? Do you have enough infectious virus to be able to spread it? And so that's the important part.
I think that is a really good point. Yeah, you may not be spreading it with a really
even
low
if you're
titer.
shedding, right?
Yeah.
So
and that's another part of the science we don't fully, because what you really want to do is stop the super spreaders, and you don't ever always know who's going to be a super spreader. Generally, a super spreader is somebody who's got a pretty good viral load in a small closed area where there are a lot of people. That's a super spreader.
Yes,
and it's not because you want to be. It's not because you have a big S on your chest. It's because you got. I don't think I drew my S the right direction. I think it's all about really where you are in how much virus you're shedding and what environment you're in to give it to others. And what we know is smaller rooms, closed spaces, poor ventilation, crowds, we call those bars.
Yeah.
And other places like that. Those are the things that are going to shed the virus. That's where you're going to spread the virus. And that's where we get into trouble. Less so the outdoor environment, as we've talked about many times, because you just, all the wind currents out there tend to mix up the virus a little bit and make it a little less spreadable.
Jim wants to know why the coronavirus seems to be flourishing during this time of the year in summer when flu doesn't. What's the difference between those two viruses?
They are different. And there was all this talk about, oh gosh, it's going to get warm and the virus won't spread. And I'm like, well, it's spread in Phoenix and equatorial countries. I don't know why we think it's not going to spread now, but let's talk a little bit about that.
Yeah, you know, initially there were some opinions that it's like another respiratory virus that is typically, the respiratory viral season includes typically October to April, and this is influenza, rhinovirus, other common coronaviruses. There was the thought that it would act like that. I don't think we were ever of that opinion, just based on how it spreads and how clinically efficiently it spreads to people, that would happen. Certainly there was the other issue about, well, the warm temperatures. You know, we have to remember in your body it's pretty hot all the time. When you have a fever, it gets to be 100. We know that in the lab, when you get those samples, you have to inactivate the virus by putting it in a temperature of, what, 160 degrees for 45 minutes?
I don't know what it is. 65 Celsius, whatever the heck that is, Fahrenheit.
But that's really hot.
But to that point, you know,
toasty.
Yeah, no, normal. Just to say to the public who's listening, a normal, nice, comfortable Celsius temperature about 25 degrees.
Yes.
So
if your hot water is on full hot in your kitchen, it's at least that. Yeah.
So to your point, the ambient temperature out in the environment is not going to be enough to kill it. Certainly we know UV rays can have a lot of effect on that, but even that will take time. So yeah, we've never been really too optimistic that the summer would decrease the spread, and actually that's what we're seeing right now, is no matter if it's warm temperatures, if it's Florida, that's pretty hot, that's spreading pretty well in Florida and Texas. Unfortunately, this is just out there. I don't really believe it's going to have the seasonality as the other viruses do.
Well, and it hasn't. What we don't know is what's going to happen when it gets cold, because it's going to get worse. But I think, again, the virus has been active in cold and hot climates at the same time across the world, which is, you just step back and look at it like, well, okay, well, that's different than how some other viruses act. Because they're not active throughout the world at the same time in cold and hot climates. We tend to get a little bit of a myopic view. If it's true in the United States, it must be true. But all you have to do is step back and say, wait a minute, this virus is equally active in equatorial, hot, humid climates, or in Phoenix, Arizona, where the health system is really struggling, or Florida, as it is in some and remember, it started here up in Washington State and New York State in some areas that were colder. And so it isn't going to respect temperature. We want it to respect the temperature, but you know, the virus isn't going to do that. And I think we just have to recognize this virus doesn't respect temperature. Influenza does. That's a different virus. It has a different genetic makeup. It has a different epidemiology to it.
Penny has to travel. She's got to get on a plane, can't find Clorox wipes, wants to know if alcohol wipes that are 75% will be effective in wiping down her
man, that sounds pretty good to me. It's over that 60% number.
Over 60%. Yeah, absolutely. It should be really good.
I think you're good. And if you can't even find those, you can always get a little bottle. Well, I guess you can't take the alcohol on the plane.
Right.
So that's a problem. But in your own home, you could use isopropyl alcohol spray and a cloth.
Yeah.
That's also hard to find.
Isopropyl alcohol?
Yeah.
I've been able to get that still. But, man.
Well, again, we have good, local companies that have repurposed what they're doing. But you can either, like Dr. Stites said, you can make out of isopropyl alcohol, you can make your alcohol solution. You can make a bleach solution. The instructions are there on the CDC website. If you can carry that in a small bottle on the plane, that's going to be adequate as well.
Yeah, and one of the funny places to go look for this kind of sanitizer is a liquor store.
Oh, yeah.
So Saturday was super hot, right? It was really hot.
Maybe that's where I haven't been lately.
I know. Well, okay, so I don't drink a lot. I don't make myself like some kind of a lunch guy. But I walked into a liquor store. I really want a cold lager. I want to take it home because we're staying home every night. We're going to stay home Saturday night. I just want a cold, crisp lager. So I walk in the liquor store. Odell's, very good. And I was looking at as I went to check out, there are all these bottles of Rieger's cleaning solution at the countertop, and some are the good size. So you can go find cleaning solution. You just sometimes have to look in an unusual place. Also, don't hesitate to look at your hardware store, because they have it too.
All right, Donna wants to know, do surgeons and other medical personnel change their masks when they are doing a long surgery? If so, how often?
Okay, great question.
Yeah, I'm not a surgeon. I don't believe, sometimes surgeons will break scrub, meaning they leave the sterile area to go do one thing or another. I'm not sure, and certainly...
I think it's if their masks get wet. If
yeah.
their masks get wet, they change them. If they don't get wet, they wear them.
Just in general, yeah.
And then if they have to eat, they step out and then they'll put a new mask on. So it really depends on the circumstances and the individual. Jill, I think we have time for one more question, and then we'll probably have to wrap up.
All right. I think, too, that I'm looking through here, and I just want to acknowledge that about every third question is involving teachers and going back to school.
Yeah. Oh,
and I want everyone to know that starting next Monday, a week from today, the whole week is dedicated to that topic, that we decided that we would give the local districts an opportunity to put out. They're discussing it, and we think that those plans are going to be printed probably this week or made available. And so just acknowledging that everybody's got really, really
it's hard to wait,
questions.
though. So let's just talk a little bit about going back to school and what are the dangers inherent in that, Dana, and any thoughts that you have, because I know you have young children, too.
Yeah. Again, I think that schools are a positive thing. We've seen certainly I have, and my kids need structure, so they need to have that structure every day. We parents, for the most part, unless you have been doing homeschooling, we aren't really trained to teach our kids what they need to be taught. Schools are otherwise safe places. They do have lunches. We need the development of our children emotionally, psychologically, socially in the schools. As we move further into this and we know that the disease is spreading more and more, I think schools are the right answer, but in what way? And I'm not sure what that looks like. What it looks like today may be different than what it's going to look like in 2 weeks. So, starting with the guidance from the CDC and working in every school or every school district to try to adhere to those points of guidance as much as possible to try and reduce the risk as much as possible. Certainly, in general, for critical and severe illness, the children are not as high a proportion as the adults, so we definitely need to protect the adults who are there, the teachers, the administrators, the other support staff there. There are ways to do that. Moving forward, we have to find the best ways. Certainly, masks in the school are going to be important. We know that little kids, for the most part, are not going to have as easy a time as the older student, but that will be important. The distancing in the classroom, as that allows, is important. So we just need to continue to move through, look at your dynamics of your district and your school, and really work to adhere to the CDC guidance as much as possible to reduce that risk.
Yeah, it's going to be tough, and I don't think we know the right answer.
Right.
And then that's really the struggle that we're at. So
we'll let Tammy have the last question.
Okay.
She wants to know how long before we reach herd immunity.
Oh boy, we're not anywhere close to that yet,
Yes.
Dana.
No. So one of the big questions is, will there be herd immunity? And if there is, what exactly will that look like?
And herd immunity just means that enough people have had the virus that the virus isn't going to invade you, and when it can't find hosts, it tends to die out.
Right. Yeah, absolutely. And historically, we have said herd immunity is typically needing 80 to 90% of people exposed to that and have been infected. There have been some numbers thrown about since coronavirus that say, well, maybe we can do 60 to 70%, but that will still leave 30 to 40% of people in the United States who are susceptible to the infection. Right now, we anticipate we may be at 10, 12% maybe if we're including all the people who have been asymptomatic who've had it. So there is still a long way to go before we get to herd immunity or get to that percentage of the population who have seen the virus before. And then once you get the virus again, once you get the infection again, are you going to have no symptoms? Are you going to have mild symptoms? Are you going to have worse symptoms? We don't know. And most importantly, are you going to be able to spread that virus again to other people? So there are a lot of questions there. We are hoping to work towards herd immunity. One way to do that is vaccination. But that is still maybe 6, 9, 12 months off. So.
See, you're a pessimist. I think we're 5 to 6 months away from the vaccination. And I think that there are already companies that are gearing up with 100 to 300 million doses of vaccine that they are pretty confident is going to work. So I'm going to cross my fingers and say by January we'll have a lot of vaccine available, and that's when we're going to start accomplishing herd immunity. I'm going to hope that works. Rachel, final thoughts from your standpoint today?
Yeah, I mean, I agree with Dana, and I think on the herd immunity front, we I guess maybe I'm a bit more pessimistic. I don't think we're ever going to hit herd immunity until we have a vaccine.
Yeah, I think that's probably true.
So the question of when will we hit herd immunity is really a question of when are we going to have a vaccine that is going to be widely available.
Yeah.
Because if you think about all of the rest of the viruses that circulate in our community, we don't hit herd immunity through natural infection with most of those either. So.
Yeah, and we're trying to prevent it actually by wearing masks and things like that.
As
the
we
best
should
way
be,
to
yes.
the best way to accomplish herd immunity is to all go out and party and
Let's
not
not do
have
that.
anything, and then that's
No.
the problem is you overwhelm your healthcare systems and a
That's
lot
the
of people
issue.
die, and then that's a bad outcome, right? That's the worst outcome and things. So. And you don't want to shut down the economy again. You know, my wife and I were
Right.
down in the plaza this weekend. We had to do a little bit of shopping, and a lot of stores are struggling, and they'll tell you they're struggling. And so you don't want to shut down the economy. What we want to do is to be responsible, because we know that if you do it right, you can protect yourself. By wearing a mask, washing your hands, following the rules around social distancing, don't go into crowded places. You know, we were down there, there's a long line to get into Lululemon.
Oh, yeah,
I
it
wish people
was.
had been a little
Yeah.
more spread out in the line, but everybody had a mask on, and people were trying to be, you know, responsible as they went into the store. I think that's a really important concept. If we can just be responsible and not think that it doesn't matter to us, then we can make this work. But if we're not going to be responsible, then we're going to continue to struggle. It's not too much different than what you teach your kids when they go out and what kind of repercussions they're going to have if they come back. You tell them, hey, curfew's at midnight, don't drink, come in, and then they come in, they've had something to drink, and it's 1 a.m. You're like, you see, you didn't follow the rules here. You're going to pay the price, and what you don't want to do is have the price be getting COVID-19.
Yeah.
So. Well, I want to thank you all for being here again today. Rachel, always a pleasure to have you back
thanks
on the
for having me
show.
back.
Don't forget to take a little bit of time off and protect yourself.
Yes.
Hawk?
Yeah.
Yeah, here we go. We're back
we go.
tomorrow.
We're back
we have a
at
pretty
it.
cool, we have an interesting guest tomorrow. Tomorrow we have Anil, I'm going to probably not say his last name correctly, Garmalker, who lives in rural Kansas. He is a COVID-19 survivor. Neil was life-flighted to us in April, and he was really ill at that time. He's a father of 9. He was put on a ventilator, and he's going to talk to us a little bit about his story of illness and recovery. And we look forward to his being a part of our program tomorrow. And then as we send you out, we want to applaud these great folks who have their masks on. Kudos to Jimmy from Olathe South. Go Chiefs. We saw one last week that said, protect Patrick Mahomes, wear a mask. I think that's a great point. Thanks also to Tiffany. She's going out to the grocery store, and she's got her mask on, nice and colorful. Rock Chalk Jayhawk, Natalie is in her Jayhawk mask, well done. And then Paul is in his Royals mask, and we don't know the name of the other fan, but we thank you all for keeping each other safe, and keeping us all safe. It's really about that. If we can just try and stay safe, then we can make this work, and we're going to survive. And it's not going to be like what we want it to be for a little longer. Right. Hawk says up to a year. You're saying for a little while. I'm saying 6 months. I think we're over halfway through it. But we can get there if we do it together. We keep ourselves together, and we keep each other safe. And remember, until tomorrow, there's still no place like home. We'll see you then.